Herkese merhaba.
Hello. It's really late. It's already dark outside. It's almost nighttime. So thank you for being with us. And secondly, I'd like to thank the organization committee for making this event possible. It's been a great congress full of rich content, and I also would like to thank them for giving me this opportunity. Elimination disorders is not a subject that interests us, but the studies reveal that elimination disorders, when patients come to the clinics, these patients are sent to GI specialists or urologists or nephrologists. And as you know, we have quite a hectic schedule, so we can't necessarily focus on these patients with elimination disorders. We try to send them away to other specialists, it seems. But what is new? What has been done of late? Actually, since antiquity, enuresis is a disease that has been known. Is there anything new under the sun? I was a bit disappointed because it seems as if there isn't any earth-shattering findings out there, but there are certain trials. Urologists especially are studying this phenomenon, but these studies are narrow in scope. And what I mean by a narrow scope is this. Rather than placebo-controlled trials, there are open-ended studies on enuresis, and the sample size is rather limited. Here's a quote about enuresis. 40 out of 100 children that go to urology clinics suffer some sort of enuresis. About only 7 of the 100 kids that come to the psychiatry department suffer from enuresis. Maybe that's why we are not so interested in enuresis. So, how about the contents of my presentation? I will not go into details vis-a-vis the diagnosis. I will only talk about treatment guidelines, and then I will give you some examples from a couple of recent studies. But before that, let's recognize altogether that elimination disorders comprise a heterogeneous group of disturbances, and I also would like to tell you a little bit about the physiology. This is quite widespread. In 7-year-olds, 10% of the children have nocturnal enuresis. Enuresis and nocturnal enuresis is more widespread. 2 to 3% have this during daytime diurnal urinary incontinence. As for fecal incontinence, only 1 to 3% of the children of this age group suffer from this. Lower urinary tract and anorectal functions involve complex neurobiological behaviors. Here we have cerebral and spinal cord centers, we have autonomic subsystems, we have motor and sensory functions, we have the pelvic floor and visceral coordination, and we also have smooth and striated muscle components coordinated through frontal lobe arousal activation centers. So, continence. What can be said about continence? What is needed in the neurobiological system? A certain level of maturation is needed. Why is this important? This is important because of 2 reasons. First of all, we see patients with a late maturation, mental retardation, autism, developmental retardation. We see more of these conditions. And normal children with delayed continence likely have a specific subsystem-related maturational delay, and we also see a lot of these conditions there. The development in the brain and in the bladder is also sex-related. There are sex-related differences up until the age of 9, especially in boys. Development for bladder and bladder functionalities is much slower than girls. That's why in boys you see 2 to 3-fold more of enuresis up until the age of 9, that is. Now I'm going to skip this. Cortico-leasing factor is important here. It is one of the mechanisms that regulate the whole system. Adrenergic system is important. Serotonergic system is also may also be important, but in terms of bladder functions and anal functions, it may have an impact, it is suggested. Corticotropin releasing factor is the most important component here, and in anxiety disorders this is also quite important. It's a very important neurotransmitter, and when there is anxiety disorder in kids, it makes sense that this condition is seen much more. How about primary enuresis? Bedwetting since birth is observed in these kids for more than 6 months. And what are the possible reasons? Developmental retardation, I talked about that at the beginning. Antidiuretic hormone secretion at night, it is suggested. Deep sleep, sleepers, and also sleep disorders may be the reason for primary enuresis. Detrusor muscles overactivity may also result in this. Genetic predisposition is something that we discuss quite frequently, but we know that there is genetic transference, but in the genes that were studied, researchers could not find a 100% chromosome link. Constipation is also another risk factor for primary enuresis. As for secondary enuresis, we say for a couple of additional diseases, the same factors play an important role. Nocturnal polyuria, reduced ADH production, or excessive urine production. Also, high waking thresholds or an obstruction in the upper respiratory tract might trigger this. Cystitis, erectile obstruction, and neurogenic bladder may also cause secondary enuresis. As for encompresses, possible causes, actually diet has an important role to play here. Why is diet so important? Because the most common type of encompresses is a constipation, a specific type of constipation, and this is caused by junk food, diets that are high in fat and sugar, or not getting enough fiber, not drinking enough water, not exercising may cause this. Refusing to use public bathrooms, because this also triggers constipation. And during the toilet training, if the children experience pain, or if they experience constipation, autism, mental retardation, developmental difficulties, learning disabilities, attention deficit disorders, conduct or oppositional disorders, obsessive compulsive disorders, all these neurodevelopmental disorders increase propensity towards encopresis. And also having a poor ability to identify physical sensations or symptoms may cause this, because the child may not sense that their rectum is full. Also, having suffered from abuse or neglect causes encompresses, but of course not every child with encompresses means well, this doesn't mean that every child that is encompresses has been subject to abuse. Also, there are more than one etiologic factors at play here. Now, when we look at the guidelines about enuresis, if there's constipation, first of all, that should be treated. And there's a bowel regulation protocol that can be adhered to. And if there's constipation during enuresis, the family should be informed as well as the child. It's very important that the family and the child knows about this condition and how the condition will be aggravated or elevated. It's vital for the treatment of enuresis. So if this is not enough, what is done? We use the alarm system that can prove successful. If it is unsuccessful, or if the parent declines use, then desmopressin, imipramine can be used. Desmopressin may be used. Imipramine is something that we use a lot, but in many of the newer guidelines, it does not exist due to cardiac side effects. And if desmopressin does not bring success, then combined treatment is recommended. In Turkey, I found this Turkish guideline prepared by urologists, and I was quite amazed to discover this, but here as well, similar options are suggested. It is not drastically different than the others. So some of the things that are suggested here do not include tricyclics. This is a guideline from Australia. It's also quite similar, and maybe the sequencing is slightly different, but still it's quite similar to the previous two. Now, monosymptomatic nocturnal enuresis. This is not a part of DSM-5. This is taken from a diagnostic criteria, and urologists use this a lot. So what is MNE? If during the day the patient does not urinate frequently, or if there is no problem during the day, but if there is a nocturnal bedwetting, then this can be classified as monosymptomatic nocturnal enuresis. So psychoeducation is the first option here. Diary might also be another option, and this is quite important. The frequency of urination is very important. 4 or 7 times should be the average number. If it's less than 4, if the urination is less than 4 during the day, then we should be alarmed. This could signify a problem, and if it's more than 7, it can also be problematic, and it should be recorded. The time of urination and the amount of urination should be registered in total. In clinical practice, it's a tad difficult to implement. It seemed at first, but maybe in the future, especially for refractory cases, because, we may not be able to apply this to every child with enuresis, but maybe in refractory children, such a diary might be of use. The alarm system, actually, this is used quite frequently, and in my clinical practice, we use this as well, and Dr. Pınar also talked about this previously, and I tried the alarm a couple of times, but I did not. The families could not really exhibit compliance to this. Maybe after my presentation you can share your experiences with me. Desmopressin. Urologists use this agent a lot. I have had some experiences with desmopressin, which I will share with you later on. And combination therapy is not something that I have tried. If you're experienced with this, maybe you can share this with us later on. Now, the alarm. This is the first option that is proposed. There are so many proofs that it works. From a scientific point of view, it does work. It's appropriate for children aged 7 years and plus, but even if the child is not 7 yet, if the child can understand how it works, and if the family can also cooperate, then those children can also benefit from this. A minimum of 3 months is required, and if it's successful, it can be continued after 3 to 6 months. The most positive thing that can be said about the alarm is this. Among all these treatments, it has the highest long-term success rate, but the progress will need to be recorded, and to follow up on the progress, and also the child and the parents have to be motivated to use this treatment, and it may take a few weeks before the alarm starts to have an effect, and it may take weeks before dry nights are achieved. So if the child is going to go to a boarding school or to a slumber party, this may not be a suitable treatment. As for desmopressin, this is indicated for children aged 7 and above, and or children aged 5 to 7 years, if rapid onset and or short-term improvement in bedwetting is the treatment priority. And it's been proven to be effective by clinical trials, and this may reduce enuresis due to high nocturnal urine volumes in children with reduced nighttime antidiuretic hormone dysregulation. But if there's a coexisting bladder dysfunction, it is not effective. So what's new? There's this novel oral tablet that is a fast-melting oral form, and recent studies have shown, and we will take a look at the side effects later on, but this has a lower side effect profile and there's a higher adherence, and this is true for oral forms as well. Nasal forms are not recommended anymore. Maybe we could discuss this later on. Hypernatremia and water intoxication are the reasons why nasal forms are not recommended anymore, because certain problems have been observed, so it is no longer recommended, and this was something new for me as well. In clinical practice, you need to give this to children above the age of 12, taken 1 hour before the last void before bedtime, and we give desmopressin 1 hour before bedtime, and 1 hour before that the child stops taking liquids. It's fast acting. However, the author says it's fast acting, but you need to wait for 2 to 6 weeks. In refractory patients, it should be continued for 3 months. Here as well, the patient must be educated against regarding hyponatremia and water intoxication. Otherwise, these kids end up in the emergency department with symptoms including headache, nausea, and vomiting, hyponatremia and water intoxication symptoms. So the family must be trained, and self-titration of medication should be avoided. That should be stated loud and clear. Now, when there is no response, what will we take a look at first? First of all, whether the medication is taken correctly. 30% of the children do not take the medication correctly, it is estimated. So retraining the families and the patients is important. If still it doesn't work, then anticholinergics should be combined with desmopressin. When you add anticholinergics, there are two anticholinergics here. There are open-ended studies that show efficacy, but there are no placebo-controlled trials, but people say it's efficacious. Alarm treatment combined with desmopressin, there's low-level response, and some people say the response is good, some people say it doesn't make sense. So for the time being, it's not really recommended. Tricyclic antidepressants are used when there is no response whatsoever. So how are we going to use them? 10 milligrams, 25 milligrams, based on the weight of the child is the suggestion. We need to gradually increase the dosage and start at the lowest dose possible. ECG checks should also be performed. Other drugs and interventions: methylphenidate, atomycin, acupuncture, hypnosis, and electrical neural stimulation are seen. In the recent studies, especially in ADHD children, enuresis is seen quite frequently, and methylphenidate regulates the ADHD symptoms, and without the need of an additional medication, without use of calendars, neuroticism can also be improved. So we need to wrap up. I'm sorry, says the moderator. So atomoxetine alone or methylphenidate should be given to the patients. As for acupuncture, there is also something quite interesting. I thought these were quite interesting. These are the sites of acupuncture, and there is a study that was done in Turkey, a comparison of acupuncture with placebo, and it was demonstrated to be efficacious. But of course, there is more to be done vis-a-vis acupuncture, and these are more things that would interest the urologists. Now let's move on to encopresis. There's nothing new under the sun. First you treat constipation, and if there's a comorbidity you treat that as well. As for conclusions, finally, here's what I would like to say. Elimination disorders are not elimination disorders only. They may also be a problem of storage, and we need to do all the clinical assessment necessary, and methylphenidate and acupuncture can work, and we need more studies with larger sample sizes. Thank you.